Welcome to Uncle Jimmy's podcast. Sit back, relax, and enjoy the conversation.
What do you both think about fear?
I'm not in this world to live up to your expectations. I'm here to live up to mine.
He who is not courageous enough to take risks will accomplish nothing in life.
Fear is a teacher.
And I don't skip class.
All right, everybody. Welcome back to Uncle Jimmy's podcast. I'm your host. And if you're new here, this is the place where we go all in. No half measures, no surface level conversations, no feel good fluff without the depth to back it up. We talk about what it actually takes to build a life worth living. Mind, body, spirit, the whole picture. And today is going to be one of those episodes I've been genuinely fired up about. Because as I say to all the guests, all the listeners, you guys don't know the conversation we have behind the scenes. And I'm telling you, we just had a great one. Quick, but so I'm fired up. So here's the thing, right? Most of us are walking around with a time bomb in our chest and we don't even know it. Heart disease, stroke, dementia. These aren't just words on a doctor's pamphlet. These are things that steal fathers from their kids, grandmothers from their grandchildren, best friends from their people. And the cruel irony, in many cases, it didn't have to happen. The information was there, the science was there, but nobody ever explained it in a way that made sense until now. He is a physical therapist, a PhD. He's also a pastor, a former Ivy League track athlete, and the clearest voice in America on why your cholesterol panel might be lying to you. My guest today holds more credentials than Bobby Kennedy. He also holds more credentials than most hospital departments combined. PhD, doctorate in physical therapy, master's as a physician's assistant, board-certified clinical lipid specialist, certified strength and conditioning specialist. His PhD research dove deep into the connection between cholesterol and Alzheimer's disease. He spent years in endocrinology, which I love the endocrinology department where I go because they are friggin' the best. He teaches lipid physiology, I might have said that wrong, as an adjunct professor at multiple medical programs. He's one of the most sought-after voices on cardiovascular health in the country. But here's what makes him different. He doesn't talk to you like you're in a lecture hall. He talks to you like you matter, because to him, you do. He just released a book that is making serious noise. The Home Security System in the Lipid Neighborhood, Uncomplicating Cholesterol and Cardiovascular Disease. And I promise you, by the time this episode is over, you are going to look at your next blood panel in a completely different way. Ladies and gentlemen, it's my genuine honor to welcome to Uncle Jimmy's podcast, Dr. Josh Wageman. Josh, how are we doing?
I am doing fantastic, man. I think people will almost think I'm cool with how all those things that you said. You're far too kind. I think that really what Uncle Jimmy meant to say was I have very few useful skills except going to school and taking tests. And so that's what you can glean from the obnoxiously viscous alphabet soup of letters behind my name. But I've been very, very blessed to have many experiences, many opportunities, and I'm just trying to pay it forward with all the blessings that I've been given. And what I try to do is bring clarity and hilarity to a historically contentious, confusing, and controversial topic, which is cholesterol, so that we can all add some life to our years and not have heart attacks, strokes, and down the line dementia.
Yeah. So Josh, I have to say, right, reading your background, I kept thinking, this guy is not what I expected from someone, right, who spends his days talking about cholesterol. You're a track athlete, right? An Ivy League graduate, a youth pastor, physical therapist, PhD researcher, and somehow all of that conversion become one of the country's foremost experts on lipids and cardiovascular disease. So before we get into the science, right, we're absolutely going there. I want to understand the person, right? Because the best messengers always have the best stories. And I think yours is one people need to hear.
Yeah, I mean, and people want a story, right? I mean, when you start going off the rails in these esoteric biochemical signaling pathways, you lose your friends pretty quickly. And I'm a disaster in a lot of ways, as my wife will tell you. And so I need to have lots of friends because I have very few useful skills. And so yeah, I'm sort of like an academic platypus of some kind, because people look at these things, are like, this does not make sense, this combination of all of these credentials and certifications and all these things. But really, I don't know. I have a restless mind, I suppose. And ultimately, too, a lot of the reason why I went to school for so long is because I had some pretty shallow motivations. For the first time I went to grad school, I went to physical therapy school because I had eligibility to still run cross country and track. And hey, athletics are awesome and movement is medicine, motion is lotion, whatever you want to say. But it was too important to me. I based a lot of my identity on my athletic prowess.
Like a lot of people do, yeah.
Yeah, and I mean, I worked really hard to still be pretty mediocre. When you run at the Division I level, you realize how good you're not. You know, people who don't know any better are like, oh yeah, I know you're really fast, and I'm like, yeah, just don't come out and watch the guys from Northern Arizona lap me in a 5K. That's depressing, you know. And so anyway, it was super fun, but I got really sick actually when I was in grad school the first time, and so it was kind of a perfect storm of a lot of different things, and no one could really figure it out. And so that is what got me into biochemistry and endocrinology, because people really couldn't figure it out. And I went from being super fit guy to I was so sick at one point I could barely go up a flight of stairs without passing out. And so it was rough. And so, but I believe God uses even the trials and the tribulations to catalyze what you're supposed to do when you grow up. And I thankfully went back to PT school and practiced as a physical therapist for years, and that was wonderful. And anytime you're able to actually be involved with somebody's life and meet people and hopefully help them in their life journey, it's worth it. And so it was really, really neat to have that opportunity, but there was never a sense of finality that I was done with school. And so at that point I was like, well, you know, I'm not getting any younger. So the quickest means to my end to save the world from all sorts of metabolic derangements, I thought, was to go to PA school. And so I went to the Yale School of Medicine. That was a blast. I loved that and fun times. And I was practicing clinically in endocrinology. And what's kind of funny is I wish I had this humanitarian reason for becoming a lipid specialist and writing books about cardiovascular disease and cholesterol homeostasis. But really how it happened was I was sitting there and a patient canceled, and it was a dark January day and in Idaho, and I'm always reading stuff, and I pull up this article and it had this obnoxiously condescending title, something like Basics of Cholesterol Homeostasis. And it was supposed to be this rudimentary review of lipids and lipoproteins. And I was thinking, oh, okay, you know, I'm pretty hip on my pentose phosphate pathway, and I've got all the steps of the Krebs cycle memorized. You know, I'm pretty good at biochemistry, I thought. I was like, how hard can this stuff be? And I read this article. It's supposed to be like, okay, yeah, you know, this is pretty basic. And I barely understood any of it, and it made me mad. And so that's what set me off on this path.
So that's what fueled you, not being able to understand what you were reading.
Well, yeah. And I was like, well, that's unacceptable, you know. And the thing is, you know, cholesterol is interesting because it almost has a religious standpoint to it. I mean, people get very tribal about it, and you'll have some shirtless influencer saying one thing, you'll have some physician in an ivory tower saying another, and people just don't know what's true. And I was like, you know what? I'm going to invest myself in the biochemistry that the good Lord hath ordained, and I am going to devote myself to having an understanding of cholesterol, because I think it matters. Because a lack of cholesterol is incompatible with life, but you cannot have atherosclerosis, so plaque in your arterial beds, without a cholesterol-laden perpetrator in the wrong place at the wrong time. And so, like most things in biology, it's not a good or bad sort of discussion. It's a context-dependent discussion. And since there's a lot to it, I have to write books about it. I can't just say one thing and then we can carry on our merry way. And so anyway, so that's what really started this thing. And then I can't help myself. So I pursued a PhD studying cholesterol disturbances and Alzheimer's disease, because there's a big difference between living and existing. And I think all of us have probably been adversely affected by the ravages of neurodegenerative disease. And I'm actually really, really optimistic that we will be able to get ahead of the game and have a preventive approach to neurodegenerative disease like we do with cardiovascular disease, like we do with insulin resistance, and really help shift the paradigm from reactionary to preventive when it comes to all these chronic diseases. And the brain's kind of the final frontier. You think cholesterol below the brain's complicated, you get up in the brain, that's a real trip. And so anyway, since I love the exploration of these things, and these things are so humbling. I've been blessed to learn a lot of stuff, and I learn stuff every day about cholesterol.
If you're not learning every day, if you're not learning every day, you're not growing.
I mean, what I say is God gave us bodies to move and minds to learn. So why would I want to stop doing either of those things? And so it's a real blessing. And I feel phenomenally blessed to be able to do these things, and hopefully not just learn stuff just to feel nice about the newest enzyme that I discovered today, but to actually be able to impact somebody's life, and be able to explain it in a way that might help them with their quality of life and in their quest to mitigate their risk of things you don't want, like heart attacks and strokes. And so anyway, it's been a fun ride. It continues to be a fun ride. And, I Like you said, I did the youth ministries for 13 and a half years at a church in Boise, Idaho. And now my primary, I would say, ministry would be coaching cross country and track. I coach cross country and track at one of the high schools in the Boise area. And that's
Are you still faster than all the kids on the team or what?
Well, see, here's the thing. If you hold serve long enough and you don't completely physically fall apart, you end up being really fast for an old guy. So, because I'll be 40 this year. And so what's funny is, I run around with the kid. We were running this morning. We're always running. And they'll say, oh yeah, Coach Josh, he's really old, but he's really fast for an old guy. So I know I've arrived at a special place in the world it's funny because, long gone are the days when you could roll out of bed in a semi-conscious state, you're dunking basketballs and all the things that
just take off, right?
When I was 20. I mean, when you're 20, you're not invincible, but man, you're a lot closer to it than now. Because nowadays, I say I still do the same things I've always done. I'm just worse at them, and I hurt much more after. And so, anyway, but you know what?
You're still keeping the mind sharp, right? You're still keeping the mind sharp.
And it does. Exercise is pretty much the best thing you can do for your clarity and your mental health as well. But anyway, so.
Yeah, I tell people getting out, right? Touching the ground, ground and getting out, touching the ground, putting your feet in the grass, right?
For sure.
Barefoot.
Dude, I love it, man. And we'll just say I'm pretty fast for an old guy, but I'm well past my prime. We'll say that too. So
no. So you got it going on, right? So you've got a PhD, right? Focused specifically on cholesterol disturbances, right? And Alzheimer's disease, right? Most people don't connect those two dots, lipids and dementia, right? Can you open that door for us? And what is the relationship? Sorry about that. What's the relationship between what's happening in your arteries and what's happening in your brain?
I think, so because this is a great discussion. I mean, everybody wants to hop into the dementia discussion because it's kind of interesting. You'll say, oh yeah, I don't want you to have a heart attack. And people are like, oh yeah, okay, that's probably good. And then you say, I don't want you to have a stroke. And a few more people start listening. When you say, hey, let's prevent dementia, everybody's listening, and so it's really an interesting and very important topic. What I'm going to do though is, in general, what's good for the heart's good for the brain, but there are some specific nuances when it comes to cholesterol regulation in the brain. And so what I'm going to do is take a step back and kind of give us a framework for cholesterol in general for the whole body. And then we can talk about how that can potentially affect what's going on with cholesterol regulation in the brain. And so what I say is, for everybody who does not want to have heart attack, strokes, and underlying dementia, I want you to have a great metabolic home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs, because those are bad. Those are axioms. There are very few things in biology that you can take to the bank, but nobody's New Year's resolution is to be more insulin resistant. Okay. And that goes along with the normal blood sugar. Nobody ever said, I think I wish my blood pressure was 240 over 140. That's not okay. No, that is not good. Nobody ever said, I wish I was more inflamed. Life would be better if I was just more inflamed. It is not, actually. And then today is not a good day to start doing meth. So anyway, those are the things that you can take to the bank. Okay. And so four pillars of the home security system. But then your lipid neighborhood, that's your cholesterol panel. Because every ApoB containing particle, and the majority of those particles are LDL particles, which have historically been called the bad cholesterol, but every LDL particle is potentially, not necessarily, but potentially a criminal that can infiltrate your arterial abode. And then the LP(a) particles, those are the felons, because per particle, they're about 6.5 times as likely to cause mischief than your run-of-the-mill LDL particle, and that's a separate thing you have to have tested. So we can always look at the pillars of your home security system as far as measuring those things, or asking you if you are smoking or doing other illicit things. And so we are always looking at those, and we can look at your cholesterol panel to get an idea of what your lipid neighborhoods look like. But people don't live on paper. It might look like you're living in a rough inner city neighborhood on paper when we look at your cholesterol panel, but do we have better ways, especially in midlife, that can inform our decision-making process when it comes to having a conversation about possibly moving to a safer lipid neighborhood? We do. And so one of my catchphrases is, got plaque, get a CAC. What's a CAC? Coronary artery calcium score. I call it the colonoscopy of the heart without the nasty pregame show, because anybody who's ever done a bowel prep for a colonoscopy knows how that will temporarily really ruin your social life, and it will probably destroy your bathroom. But with a CAC, it's a low-dose CT scan, about the same amount of radiation as a mammogram, so virtually nothing. And it shows if you have calcified plaque in your coronary arteries, which is a late finding in this whole process of atherosclerosis. It shows there's been a break-in. And you cannot have atherosclerosis without a cholesterol-laden perpetrator breaking into the wrong place at the wrong time. And then there's a maladaptive immune response that ensues that results in that plaque formation. And so this is the basic framework. We can look at these things. We need to look at your home security system, but we also need to look at your lipid neighborhood. And then to make better sense of that lipid neighborhood, we can get these imaging techniques that can inform us of maybe how aggressive we need to be at moving you from the rough neighborhood where there's been a break-in, if that's the case, to a nice, safe, gated community with fewer lipid criminals. And so that's kind of the basic framework of the home security system in the lipid neighborhood. And then we further unpack the purpose of all these things and the purpose of these lipid-laden particles. And so one of the things that people think is, LDL is bad. It's been called the bad cholesterol. All these things are bad. They're out to kill you. Well, really, no. All these things are lipoproteins because water and fat don't mix, and your blood is mostly water, so it's got to have a way to get through your bloodstream. And the lipoproteins are the way that fats are transported throughout your bloodstream. And so we call them water-soluble lipid transportation vehicles. They're mailmen, essentially. The VLDL, IDL, LDL particles, which are these ApoB particles, B for bad if it's in the wrong place, but otherwise not so much, they're mailmen. Their job is to deliver triglycerides, phospholipids, some fat-soluble vitamins, occasionally some cholesterol to target tissues, and then go home to the end of the day to the liver. And so these guys aren't inherently bad. However, what if that mailman runs his truck in your arterial wall? That's a bad mailman, and there's been a crime. And that's where that plaque formation can ensue when there has been a crime committed in the arterial wall. And that's why all these factors matter, because these mailmen, well, how are they going to deliver the mail? Well, they need an accurate GPS system. And ideally, it's hard to, drive in a snowstorm. You guys get it on the East Coast. I lived the song Jesus Take the Wheel at one point and flipped my car a couple times in a blizzard. Well, if you're caught in a sugar storm, which would be diabetes, well, those mailmen, they're a lot more likely to get in a wreck. And that's why there's a 2 to 4-fold increased risk of coronary disease in people who have diabetes. That's not good to get caught in a sugar storm. Additionally, if someone has insulin resistance, the mailboxes are full. The mailmen are trying to deliver triglycerides, but, the mailbox full, they're going to keep driving around. And if they're driving around not going home at the end of the day, you might be asking for trouble. So all these factors come into play. It's not just, let's just look at your cholesterol, or let's just look at your blood sugar, or just look at one thing. No, we need to look at all of them.
All of it, yeah.
And all of it. And that's why I'm not a fan of just these risk calculators. So a lot of clinicians get taught to use like these 10-year risk calculators or 30-year risk calculators, these things that you can plug in numbers and it spits out some percentage likelihood of how likely you are to die in the next few years. And that's not really helpful. We have to look at each individual. We have to look at all of the risk factors and then make our decisions based on the person in front of you rather than population level data. And so since there's a lot to know, got to write books about it because there isn't just one thing to look at. We need to have an understanding of all these things and how they're supposed to work, but what can conversely go wrong. And so that's our basic framework for everything, particularly when it comes to regulation of these cholesterol particles below the.
Yeah. So like I was saying to you, right? So the correlation, right, between Alzheimer's disease, right, and cholesterol, right?
Yeah.
So when did the research, right, community start taking this connection seriously?
Well, honestly, the first guy who took it seriously was Alzheimer himself, because one of the first things that he noticed in people who were manifesting these signs of cognitive decline was toxic lipid droplets. And so these fatty clumps accumulating in places where they didn't belong. But unfortunately, I think that kind of got put on the back burner for a long time. And we've had a very amyloid-centric view of Alzheimer's. And what's interesting is when you look at Alzheimer's disease or Parkinson's disease and some of these other neurodegenerative diseases, they have all distinct protein signatures, but I think there's a lot of overlap between all of them. I would say it's more of a continuum, and there are certain specific signs that would say, oh, that person has Parkinson's, if the person has tremor and some of these freezing episodes and the rigidity and some of the things that go into Parkinson's, and the brain area affected is a region called the basal ganglia and a depletion of dopamine in the substantia nigra and the basal ganglia. And so there's different things that will say, oh yeah, that's Parkinson. But a lot of people who have Parkinson's also have amyloid, which is an abnormal protein that aggregates primarily in Alzheimer's disease. So there's overlap with all these things. But there is an abnormal protein called amyloid that accumulates in people with Alzheimer's. That's true. And then there's also something called tau and hyperphosphorylated tau and neurofibrillary tangles. So there's these things that we see, particularly in postmortem studies of people in Alzheimer's disease. And yet we don't really want to wait around for people to die in order to figure out, oh yeah, you had that, do we? I think it's better to say, maybe there's something that happens sooner than that. What are some of the things that would portend, oh, this person might progress to Alzheimer's disease? And yes, when you're a hammer, everything looks like a nail. I'm a lipid specialist, but I believe that ultimately Alzheimer's disease is more of a lipid disorder than it is just focusing on some of these other downstream proteins that, yes, they do manifest in this disease process, but I'd say we're probably getting there a little too late. So taking a step back. So in general, what's good for the heart's good for the brain. And so some of the things that we do see that would predict somebody progressing to Alzheimer's disease would be high insulin levels. One of my mantras is control your insulin, control your life, because it's not just about keeping blood sugars normal. It's about making the minimum effective dose of insulin to keep those blood sugars normal. And so hyperinsulinemia is associated with about a 2.2-fold increased risk of Alzheimer's. Additionally, one of the first disturbances we see in the brains is decreased glucose utilization, so sugar utilization in the brain in people that go on to develop Alzheimer's disease. People with diabetes have about a 56% increased risk of getting Alzheimer's disease. And we know that that's all about impaired glucose utilization. Sounds a lot like the home security system type stuff. And visceral adiposity is associated with increased risk of Alzheimer's disease. And then people who have high CAC scores, that CAC I was talking about, got plaque, get a CAC. People who have the highest CAC scores in something called the MESA. It's a biobank. The MESA study actually have the highest incidence of dementia. And then people who have coronary disease, so who have had cardiovascular events in midlife, tend to have an increased risk of Alzheimer's as well. So all these things are kind of making sense. But there are some peculiarities when it comes to the brain, because what I talked about was the ApoB mailmen are the mailmen below the brain that are transporting lipids. But there's a different mailman in the brain, and his name is ApoE. And some people have heard of ApoE4 because Chris Hemsworth, who descended from Mount Olympus, has 2 copies of this ApoE4 gene. I call it ApoE Thor because I think it's funny and it helps people remember. But ApoE4 is the number one identified genetic risk factor for Alzheimer's disease outside of some rare conditions in presenilin 1 and 2 and amyloid precursor protein, which are really, really rare, where people get really early Alzheimer's disease. But so ApoE4, number one genetic risk factor for Alzheimer's disease. And you get one from mom, one from dad. Most people have 2 copies of ApoE3, but he has 2 copies of ApoE4. My wife has 1 copy of ApoE4. And so, and is otherwise perfect in every way. But so it's a risk factor, but it's not deterministic. It doesn't mean that, oh, hey, even Chris Hemsworth, who has 2 copies of ApoE4, which would suggest he has a 8 to 12-fold risk of Alzheimer's disease. It doesn't mean he's going to get it. It just means he has less margin for error. And I think it's really important that all of us have picked certain parents, as if we had any control there. We all have been dealt a certain genetic hand. We all might be predisposed to one thing or another, but our genes are not our destiny. And we can take ownership of what we've been given and work with that. So anyway, so this ApoE in the brain. So ApoE is the mailman in the brain. And it's an HDL-like particle because it's in the same density range as a high-density lipoprotein, which doesn't matter. But so in the brain, which 20 to 25% of total body cholesterol is in the brain, and the half-life of cholesterol in the brain is 6 months to 5 years, and it's kept separate from the rest of the body. But with cholesterol in the brain, the astrocyte, which is a support cell. So all of the cells in the brain are meant to support the neuron because the neuron's the moneymaker. The neuron's running the show. The neuron's like the CEO executive of the entire establishment. And so the astrocyte makes the cholesterol. And then it says, hey, ApoE particle, go deliver the cholesterol to the neuron so the neuron can use it for all of the important things that the neuron uses cholesterol for. Because it's very energetically expensive to make cholesterol, and the neuron doesn't need to be wasting its time making cholesterol. It can, but it has better things to do. And so it's like, okay, here's the cholesterol, go take it to the neuron. Well, most people do a fine job of that, and they give it to the neuron uses it for all of the signal transduction and the things that it needs to. But people who have ApoE4, they tend to have a distractible mail delivery carrier. And so the ApoE4 carrier gets the cholesterol, and then it's like, oh, squirrel, and it gets lost along the way, and it doesn't deliver the cholesterol to the neuron. It leaves it somewhere else. It leaves some cholesterol messes in the brain, and cholesterol, when it's in the wrong place, is actually quite toxic to cells. Conversely, a lack of cholesterol is incompatible with life. So there's always a sweet spot. So when it leaves cholesterol messes though, well, what happens? Your inflammatory cells in the brain, the microglia, get annoyed and they're like, what is this mess? And so they actually mount an inflammatory response to clean up the mess. And additionally, the neuron's like, well, where's the cholesterol? So the neuron starts making its own. But when the CEO or the executive starts having to do the work of one of the support staff, you're asking for burnout. And what we see long-term in people with Alzheimer's disease is we see decreased cholesterol transport. We see impaired cholesterol elimination. So these toxic lipid droplets accumulate and they're not supposed to. And then we also see decreased cholesterol synthesis over time. And so it negatively feeds back on the cholesterol synthetic pathway. And so we see those things pretty consistently in people who have Alzheimer's disease. And I do think that there are some unifying principles as far as that decreased cholesterol transport. When that goes wrong, then we're just asking for burnout long term. So anyway, so hopefully that's very, very complicated stuff up there. And it requires, I think, a good understanding of what's below the brain to say, oh yeah, I'm starting to vibe with that. But hopefully that kind of paints the picture that we want there when it comes to some of the lipid disturbances that we see in neurodegenerative disease.
Yeah. So let's talk about the book, right? The home security system and the lipid neighborhood, right? I love the title because it sounds like a metaphor, and I'm guessing that's very much by design. Walk us through the concept, right? And why did you frame cholesterol education this way?
Yeah. So people like stories. People learn best, I think, through metaphors and things that are relatable to them. You know, I'm a weird guy. And when I start getting excited about Niemann-Pick C1-like-1 and PI3 kinase AKT signaling and throwing down some FOXO3 and FOXO1 and all these things, people are like, okay, dude, let's sit out the next few plays. You know, I don't want to be your friend anymore. And like I said, I need friends. So how this all came to be actually is I have seen a lot of patients. I want my patients to absolutely crush it at life. I do not want my patients to have heart attacks, strokes, and dementia. And I want my patients to have ownership of the process. I don't want my patients to just do what I said because, oh yeah, I said a few smart things I didn't understand. Or, you know, I'm a doctor, do this. I have expertise in this, do this. I don't think that's a good reason ever. And so to walk with me. I want to have them have ownership of the process too and come alongside them so we can get there together. And this is, you know, why I made $14 an hour with no benefits, because I would take 2 hours to explain all these things to people, you know, but at the end of the day, when people are buying in to what you're saying, because it makes sense, because they understand it, then it's awesome to see what happens. People get their lives back. People are crushing it. And it's really, really awesome. And you get to play a small role in that person optimizing the life in their years. And it's really, really rewarding. And so anyway,
don't say small role. Don't say small role because it's bigger than that.
Hey, you know, you're in the right position at the right time, you know. And so
no, because you know, I was saying to you, my team, right? My endocrinologist on down to the nutritionist and everybody else, right? Without them, without that support from the doctor on down, I say it, I mean it, I wouldn't be on this journey and where I'm at, you know, not just through hard work, but also through, you know, meetings with them, making sure I'm eating right, following up with the doctor. And, you know, and what I love about my endocrinologist is, you know, he's intelligent, but he also hits you with the facts and he talks to you one-on-one, right? There's no BS, nothing. It's, hey, this is, you know, what we should do. This is what we should try. And we can try this or we can try that, you know, but he doesn't, you know, sit there and talk to you like, hey, I'm the doctor. I'm telling you what to do. It's your option, right? Like you said, we're in this together. You know?
Yeah. And it takes a village, you know, and having the support of people who are truly in your corner and no one cares how much you know till they know how much you care. You know, you can know all the stuff, but without love, you're a noisy cymbal and a clanging gong. And so, and you know what we do with gongs, people want to hit them, you know, and so you don't want people just to want to hit you. You want to actually come alongside them and help them out. Yeah. And so it's really, really special when you get to do that. And so I started using all the metaphors that I use including just the framework, the home security system, the lipid neighborhood, like discussed, and talking about mailmen and talking about why we were doing this. And people are like, oh, that makes sense. And when something makes sense, then they're usually gonna comply with whatever you're recommending. And so it was really cool. And then I would use these same metaphors when I would teach lipid physiology at the medical programs that I teach at. And the students seem to be getting it too. And then over time, my patients and my students were like, you know, you should really write a book. And I was like, oh, yeah, you know, thanks. That's nice. That's nice. And then a few more people said, you should write a book. And then when I started working for this biotech company, I would teach lipids to all the people at the biotech company. And they're like, dude, really should write a book. And enough people said it over time. I was like, okay, fine. And so anyway, so I wrote a book. And it's been a
I can't wait for you to send me a copy of it.
And
nice
no,
copy
I totally
signed.
will. I for sure. And you just give me that mailing address offline. We probably don't want to broadcast this for
everybody knows where I live. I was out there doing a live last night.
Yeah.
So
here, let me put my social security number in the chat. But no. So and I would be honored to send you.
No, that must have been pretty cool, right? Everybody telling you to the point where you were probably like, you got to do it.
So I did. And ultimately, the first edition is what people should read. There's actually a remixed second edition for the clinician and anyone on a mission for more lipid tuition, because sometimes I rap about these things. And actually, some of the cardiovascular conferences, I will rap about lipids there and parody certain things and throw down if that's what the people want. But anyway, so I have the second edition.
For the people.
It's for the people, it's for the fans. But anyway, so there's a second edition that's like twice as thick. And if you want to pass your lipid board exam as a physician or healthcare practitioner, you should get that one. But there's like 12 people worldwide that are in that boat. So anyway, that one, I don't say, hey, go get that one. No, that's just whatever. The first one. So
that'd be for the doctor, right? The doctor,
yeah, but even doctors, we just don't really get taught this stuff in medical programs. And so I would say for even the doctors, the first edition is the one to read. The second edition is just if you really want to take it to the next level, and there's a community pool in the neighborhood of the second edition, but there's no lifeguard on duty, so it's a deep dive, enter at your own risk. And so anyway, that one, there's some real crazy topics there that come in handy when, like you said, if you want to take your lipid board exam. But in general, I say, hey, just read the first one. You will be better off than you found it if you do that. That's the whole goal anyway. So that's that. So that's how it all came to be. And what's neat is there's been quite a few people that have reached out to me who I didn't even know, who read it, and then they ended up getting a CAC and they got their Lp(a) checked and they ended up having plaque in their coronaries, but they were able to do something about it. And if something isn't actionable, I don't
until it was too late, right?
Right. But if something's actionable, then I want to know about it so we can get ahead of the game. And chapter 6 of my book is actually one of my friends, and his one risk factor was Lp(a). And he ended up having a CAC of 2,814, ended up having to have a 5-vessel bypass, but he's doing great. But he was a ticking time bomb. And so just that one thing was his issue because he picked the wrong parents, but his 10-year risk calculator was 2.3%. And so those risk calculators where everybody's like, oh, you're fine. Well, maybe not so much. Maybe there are a few more things that we should consider. And it's really cool when you can get ahead of the game and you're still running together and still doing these things together. And so anyway, there's just, I think hopefully what it can do is bring awareness to things. And, if there's, like you said, if there's one person out there that benefits, then it's all worth it.
Yeah. So here's something, right, that confuses most people, right? And I know you touched on it, briefly, but the idea of good cholesterol and bad, right?
Yeah.
You've said this framing is actually misleading, right? Break it down for us. What's the real story?
Yeah. So first off, a lack of cholesterol is incompatible with life. And so it's an important part of cell membranes. Like I said, 20 to 25% of total body cholesterol is in the brain. Pretty important in the brain. It's an important part of bile acids as far as digestion goes. It's an important precursor to steroid hormones. It is essential for life. That said, every nucleated cell in your body makes its own cholesterol. And if you and I had inadequate cellular cholesterol, we wouldn't be having this conversation. So there's a difference between cellular cholesterol and plasma cholesterol. And the plasma cholesterol is what you see on a blood panel, okay? That's only about 10% of your total body cholesterol. And that's capturing what's being transported at any moment in time by those lipoproteins. And so that's first off, we need to understand that. And so second off, LDL bad. People are like, oh, it's bad cholesterol. Well, no, once again, they're mailmen, right? VLDL, IDL, LDL particles, they're mailmen. Hopefully they deliver the mail and then they go home and deliver at the end of the day. However, the LDL particles are called bad because they linger longer than some of the other particles. They hang around for 2 or 3 or 4 days. And, those kids on the street corner, if they're not going home at the end of the day, are they doing really good, magnanimous community activities? Probably not. They're probably going to get into trouble. And so if you have some longer plasma residence time, you're more likely to get into mischief. And so that's why it's been called bad, but they're not inherently bad. And then HDL particles. HDL is called the good cholesterol. Well, this is a big fallacy because HDL does some really good things. So HDL can actually go into the scene of a crime, and it can take the cholesterol-laden perpetrator back to the liver before it causes all sorts of problems. That's pretty awesome, and that's called cholesterol efflux capacity. HDL particles can do that. That's pretty cool. HDL particles can also bind up toxins like lipopolysaccharides. So let's say someone's having sepsis. Not recommended. You're having a bad day if you are septic. But HDL can bind up the lipopolysaccharide, bring it back to the liver, and it gets excreted in the bile so you don't die. That's pretty awesome. And then HDL can actually increase glucose uptake into skeletal muscle. That's a charitable community activity. HDL is like the police force. Okay. Lots of good things, diverse roles, but just looking at the roster of the police force, the names on the roster doesn't tell you anything about whether it's a good cop, bad cop, or there's a mixture of both. You don't know anything about HDL's functionality just by looking at your HDL cholesterol on your blood panel. So there are people with super high HDL cholesterol that have dysfunctional HDL cholesterol. But a lot of times people with low HDL cholesterol do have increased risk of cardiovascular events as well. But there's a lot of exceptions and there's ethnic variations. That said, people who have low HDL cholesterol is typically associated with cardiovascular disease. But the reason for that is because when people are eating and their triglycerides stay high around the clock, what happens is the HDL cops get kind of fat and fluffy with all those triglycerides. And so what happens is your body's like, well, shoot, you guys aren't going to pass your fitness test. And so it takes a couple unskilled surgeons and tries to trim the triglycerides off of them. It overshoots the process and you're left with this gaunt, emaciated HDL. It's too weak to pass the fitness test now. And your body's like, dang it. And so it takes it out of circulation. And so when that happens over and over and over again, you see low HDL cholesterol as part of the metabolic syndrome. But it's telling you something more about the environment and the milieu and the unskilled surgeons that are in the area rather than what the HDL is doing itself. And so that's why we do see that as an association. But if you're going to use in general, but there's too many exceptions to further generalize. If you're going to use HDL cholesterol for anything, in general, it's kind of like a hemoglobin A1C of how high your triglycerides get after you eat. And so in general, that's what you're going to see. But there's a lot of exceptions. HDL is crazy, and there have been multiple drug trials trying to raise HDL cholesterol that have failed. And it's like, okay, let's just focus on the criminals. Let's just get you living in a safer lipid neighborhood because trying to address the police force is just too complicated. So there's HDL. And then one of the other fallacies and the three big fallacies I always address is like, okay, LDL bad, HDL good, everybody take a statin. And so those are the three things that's your basic curriculum when it comes to medical programs, when it comes to lipids. And then we'll go on to the next thing because it's hard and complicated. And so statins do a lot of good things, but they're not a panacea. So there are other tools beyond the statins that can help reduce cardiovascular events. And, if the year was 2004, the approach was pray and take a statin. I think we should always pray, but we have many tools beyond the statin that can help people live in a safer lipid neighborhood and reduce the risk of cardiovascular events. And so that's another topic, mainly a clinical topic with all the available options that we have therapeutically for lipid management if we need to.
So if someone listening right now, right, and they've only ever gotten a basic lipid panel, right, what should they be asking their doctor for?
Yes. And so great. If you had to pick one thing, and this would be in midlife, it would be that CAC. Got plaque? Dunno, get a CAC. And so because, hey, there are plenty of people with, quote, normal cholesterol levels who have positive calcium scores. And there was one recent study of just using risk calculators, which I am always throwing those risk calculators in the garbage.
Right out the window. Yeah.
But for good reason, okay? Because they have a new risk calculator. It's called the Prevent Risk Calculator, which recognizes some good things. It recognizes HbA1c and eGFR, which is a measure of kidney function, and UACR, which is a measure of protein in the urine. And if you're leaking protein in the urine, your home security system is not as good as you think it is. So it has some good individual characteristics to it. But there was a recent study that they used this Prevent Risk Calculator, and 51% of the people in the low risk category, which means, hey, don't do anything, you're crushing it, keep on keeping on, had a calcium score above 0, meaning you have atherosclerosis, you have heart disease. And then 35% of those people had a CAC of over 100. And that's extensive disease. And so when your risk calculator is missing people over half the time, and why are we doing this? It's kind of like,
why are we still using it?
Right. It's like I before E except after C, except for all of the exceptions. It's like, well, maybe our heuristic is just not useful at that point, is how I feel about it. And hey, once again, understand the individual utility of each biomarker, understand what each thing means, and understand that we're going to apply what we know about the entire situation to the individual in front of us rather than having some risk calculator, vomit out something on our computer screen and following some algorithm. And so that's my big thing. It's worth knowing because people matter. People are worth it. And so if I could pick one thing, especially this would be like 40 and up for sure, get a CAC, and the mean age of incident CAC in Caucasian males in a recent study was 36. So maybe we can go back sooner. The limitation of CAC, and some people like to hate on CAC because they're like, oh, it doesn't show soft plaque. Well, that's true, but as a screening test in an asymptomatic person, it's a wonderful, wonderful test. If people have access to a CT angio, which is, expensive test that shows you degree of stenosis and it shows you soft plaque, then by all means, that's a great test. But as far as just a screen in an asymptomatic person, CAC is a wonderful test in midlife as far as that goes. That said, when people are younger, if you're below 40 and you have a CAC of 0, but you still have a bunch of risk factors, I'm not feeling quite as good about you. That said, if people have a CAC of above 0 and you're age 32 to 46, you have a 5x risk of a premature event from the Cardia Consortium if we don't do something. So anyway, so it has to be taken in context once again. Your 12-year-old kid shouldn't get a CAC,
Yeah.
And so
anyone over 40 should.
Yeah, I would say for sure. And then, hey, if your family history is you have an early family history, your uncle had a heart attack at 38, well, maybe we should do it sooner. Kind of like people with colonoscopies. If you have certain risk factors or early family history, they start sooner. I would say CAC should be a similar thing. And I think that is quite reasonable. And then the one blood test I would add would be that Lp(a), which I call the felon of the lipid neighborhood. And so like my buddy, he had perfect insulin sensitivity. His blood sugars were totally normal. Blood pressure was great. HSCRP, which is a measure of systemic inflammation, was totally low. It was like 0.4.
We're going to get to that next.
Yeah, he decided to not do drugs, which is great. And so he was looking great on his home security system. And then his LDL cholesterol was like maybe 100. So it wasn't crazy high or anything. And he was telling me his family history. I'm like, dude, get your Lp(a) and get a CAC. And, he was like, what's that? And so I talked about it and then we got it. His Lp(a) was quite elevated at 128 milligrams per deciliter. And then he had that calcium score of 2,814. He had so much disease, he had to have 5 bypasses. And so anyway, but hey, he finished the half Ironman and qualified for Worlds. He's doing great. And so, but he might not be here if we hadn't.
Yeah, thank God you guys had that discussion.
Yeah, so it's good he had a weird friend, to run with him. And so, but really, so as far as just across the board in midlife, that CAC is pretty much king. And then Lp(a) is a really good thing in addition. And then the guidelines, which guidelines are guidelines, there's always some limitations to them, but now officially the guidelines say, hey, get Lp(a) checked at least once in a lifetime. And that's a good recommendation because it doesn't really vary much. It's just you either have it or you don't. And we need to know. And there are some therapies on the horizon specifically for Lp(a). So it's kind of an exciting time to be in the prevention space.
Yeah. I could see you writing a new book on little LPA.
There'll have to be an update for sure at the very least.
No doubt about it. So inflammation, right? It comes up in every serious health conversation, right? You work with markers, like you just said, HSCRP, right? And IL-6, right? In plain English, what role does inflammation play in heart disease? And are we addressing it or are we mostly just treating the symptoms?
Yeah. So inflammation, and it's always thrown around there just generally. And there's so many supplements that are probably just making you have expensive urine, but are said to be decreasing your inflammation. And it's like, oh, okay, what does that even mean? And so it's important to just know what the source of the inflammation is rather than just blitzing inflammation for inflammation's sake. And so we have to see if we can figure out why the person might be inflamed. So the most common measure of inflammation would be that HSCRP, and that's high sensitivity C-reactive protein. Now, just getting an HSCRP doesn't tell us why you're inflamed. It's non-specific. And so let's say that you go to the hospital because you have terrible right lower quadrant pain and you have appendicitis. Your CRP will go really high. Why is your HSCRP high? Because you have appendicitis. Take out your appendix, recover, your HSCRP is fine. So, okay, that's one reason why HSCRP could go up, because you're having an acute illness. But then HSCRP, it could be high in somebody who has rheumatoid arthritis or who has a systemic autoimmune condition. That's another reason why your HSCRP could be high. But far and away, the most common reason why hsCRP is high in the United States is angry adipose. Because when your body kind of resents your state of chronic overnutrition, the fat cells actually will release what's called adipokines, so inflammatory signals, and you will produce hsCRP because, or CRP, hsCRP is just the lab, but you'll produce CRP in response to what the fat cells are telling you to. And so in general, it's angry adipose. And that's why things like semaglutide and tirzepatide and some of these incretin therapies reduce hsCRP quite potently. They're making the adipose a lot less angry.
Yeah.
Now, conversely, there is a people group in Bolivia called the Shimane, and their hsCRP is 9.2 on average, which anything over 2 is an independent risk factor for cardiovascular disease. So 9.2, you must be thinking, oh, these people must have terrible heart disease. They don't have any heart disease. Why is their CRP high? Because they have parasites. And so their body's own immune response is neutralizing the parasites because their drinking water is not clean. So once again, CRP matters big time if you have a chronic inflammatory condition or if it's angry adipose or whatever. But just going after CRP itself, I don't think is the answer. It's just trying to determine why it might be high that matters more than just the inflammatory marker itself. It's not like we go take ibuprofen to prevent heart disease or something like that. IL-6 is interesting because IL-6 is actually more specific for coronary disease. And I think that's the future because it tends to be a little more specific than hsCRP. And what's interesting in genetic studies, when people have certain polymorphisms in the IL-6 gene, that's associated with coronary disease, CRP not. And so IL-6, I believe, is the future of these inflammatory markers. There's also something called glyc-A, which is a composite of different acute phase reactants, and it has a little more stability. hsCRP is a lot more volatile. And so that's why it's encouraged to, if you get an hsCRP, check it on a couple different occasions because it could just be artifact. But in general, the context will tell you and tip you off to why that CRP might be high. And, there is, like, colchicine has demonstrated in a couple older trials, Colcott and Lodoco 2, that the inflammatory component, it reduced cardiovascular events in people who had that. But some of the more recent trials weren't quite as compelling with more modern background therapies. And so I think that it's really addressing the root cause of the inflammation that matters more than just chasing that inflammatory marker. That said, the inflammatory marker is worth getting because it can tell you about their metabolic home security system, and then you can act accordingly. But once again, this whole conversation just illustrates why we need to be good clinicians. We need to not just look at these things in isolation. You have to look at the entire context with all of the things that you're getting.
Yeah, you have to look at the big picture.
Yep.
Yeah. So statins, right? The most prescribed drug in America. Millions of people are on them, right? And yet the conversation around statins has almost become political, right? There are camps of people who swear by them and camps who think they're overused or even harmful, right? Where do you land on this? And what does the actual science say?
Yeah. Statins do a lot of good things. And whenever we're talking about tools in the toolbox, rarely is there a perfect tool. Generally, there's going to be some sort of trade-off. And so, but also, it's important to use our tools intelligently. And so statins have more data in reducing cardiovascular events than any other medication. That said, if you have a calcium score of 0, a CAC of 0 in midlife, the number needed to treat with a statin, meaning that somebody actually gets benefit from this, ranges from 3,571 to infinity. So it's like, okay, well, we need to select the right person for the tool,
Yeah.
And so statins do a nice job of stabilizing plaque. So they get you living in a safer lipid neighborhood as far as LDL-C or ApoB reduction. And they also will confer some stability to plaque. And if you have any plaque in your coronaries, do I want it stable or unstable? Probably stable, right?
Stable,
and then can I further stabilize the plaque and then regress the plaque with some of our other therapies like PCSK9 inhibitors? Yes. So, okay, that seems pretty good. So we just have to understand what they do well and how to use them intelligently. Now, what I will say is the most bang for your buck you get with your statin is your first dose. Every subsequent doubling of the statin dose, you don't get a whole lot more LDL cholesterol reduction, maybe 6%, and you increase the side effects a ton. So I'm a big fan of using combination therapy and using statins in combination with ezetimibe, PCSK9 inhibitors, other things, because it makes a whole lot of sense. And I'll tell you why. So whenever you're trying to use some of these medications for someone who's been broken into, they have a high calcium score. Well, got plaque? You do. So let's stabilize it, maybe even regress it. That sounds good to me. I think that makes some sense. And that requires moving to a safer lipid neighborhood because you've been broken into. Also makes sense, I think. And this is where the data shines for any sort of lipid lowering therapy. And so when you use a statin and you decrease cholesterol synthesis, your body fights you because this is home, darn it. I've lived here my whole life. Well, yes, you have criminals invading your space. Yeah, but this is home. Your body fights you. And so whenever you decrease cholesterol synthesis with a statin, your body increases absorption of cholesterol. Well, how do we decrease absorption? Ezetimibe. Okay, so there's one study called the racing trial where upfront, low dose statin plus ezetimibe gets more people to their lipid goal, has less people discontinue it, less side effects, and at least non-inferior in the events. Numerically, it was trending in the right direction. Okay, that seems like a good approach. And then additionally, what do statins do to PCSK9 levels? And PCSK9 basically puts your LDL receptor, which is kind of like a claw grabber at the arcade that pulls in the particles and wins you the ApoB. Well, PCSK9's around, it puts your claw grabber out of commission, so you can't go win, and then all the kids are crying and getting into your arterial wall and causing heart disease. So too much PCSK9 around is not so good. Statins actually increase PCSK9 levels too, because once again, your body's fighting you. And so...
And you did your dissertation on that, right?
Yeah. And so, PCSK9 also has some really interesting roles in the central nervous system that remain to be elucidated. And so hopefully somebody out there will be listening to this and run some iPSC studies to confirm or reject my hypotheses. But anyway, so PCSK9 is really, really interesting. And so, but we have drugs that inhibit PCSK9 and they work really, really well in getting you living in a safer lipid neighborhood, stabilizing or regressing plaque, and reducing cardiovascular events. So basically all of the tools we have, and there's other tools too, can work together and work in synergy rather than just worshiping at the altar of high intensity statins, which here's one thing, because the effect on muscles, people always complain of muscle aches on statins, and people will try to discount that. I mean, it is potentially a real effect. Even in asymptomatic people, there's one study of atorvastatin where complexes 3 and 4 in your mitochondrial electron transport chain are inhibited by over 30%. And so even in asymptomatic people, so it does have some degree of inhibition of how your cellular battery is getting revved up to full capacity in muscle. So yes, this is something we need to understand, but we can mitigate most of these effects if we just use a lower dose in combination with other things. Additionally, new onset diabetes is a real effect of statins. And, I'm trying not to have diabetes here. And there's a meta-analysis of over 120,000 patients treated with statins, and new onset diabetes over 5 years in a moderate intensity statin, 10%. It's not that much more than run-of-the-mill American. You go up to high intensity, 36%. Whoa, that's a lot more. And we didn't get much more LDL cholesterol lowering out of it, did we? So I just think that we should use our tools smartly, and statins are a good tool, but they're not a panacea. And we have multiple ways to play the game to help people live in a safer lipid neighborhood. And it doesn't have to come at the expense of quality of life and your home security system if we just use the tools intelligently. And that's what I try to do. Let's act with some nuance and not just blitz people with King Kong atorvastatin. And I think we can live happily ever after and be pretty well off there.
Yeah. So let's talk about the people, right, who feel like it's too late right now, right? Someone listening who is 55, maybe 60. They haven't had a physical in years. They're scared of what they'll find out. And they've been telling themselves they'll deal with it later, right? What do you want to say to that person directly?
Hey, not knowing doesn't make it go away. And if it wasn't actionable, I wouldn't want to know. But it really is. We can do so many things. And I got your back, go get these things. Get a CAC, get a LPLA. And then find me on LinkedIn, find me somewhere. I'll help you out. I do a lot of these type of consults all the time, and I'm very, very blessed to be able to hopefully help you out on your journey. And so it's never too late. It's never too late. And the only time it's too late is when we didn't check anything and then, never
You're
wake
in the
up.
ground.
So,
you're
so
at
I
the
think
funeral
that,
parlor.
yeah. And the thing is, hey, I don't know. None of us are guaranteed tomorrow, right? But
So
I think that for as long as we're here, we can be stewards of the time we've been given, and we can add some life to our years. And let's try to do that. And I think that having a preventive approach to all these things, we absolutely can. We can take ownership of the situation, and we can crush it for as long as God keeps us around.
Yeah. So your book, right, just dropped, and you're clearly building something bigger, right? A platform, a mission, a movement around lipid education, right? I love it. Where is this going? What's the vision? What does Josh's impact look like 5 years from now?
Yeah, that is a question for the Lord Almighty. I have no idea. And this is what's funny too, because I'm not particularly driven by by career things or anything like that. And, I work with a lot of people who just want to get promoted, and there's nothing wrong with that, I guess, although it's kind of like chasing the wind. I mean, King Solomon tried all this and he was better at you and me, and he said it was all meaningless. And I agree with that. So, but at the same time, it's a gift. Each day is a gift.
No doubt about it.
And the most important
That's why it's
gifts
called the present.
for sure, dude. The present's a present, and the most priceless gifts are the people that he puts in our lives, And so, I value that. And when people ask me what my career ambitions are, I say, well, I want to walk my daughter down the aisle someday. And people are like, oh, that's nice. Because that is nice, isn't it? And so people are like, oh yeah, that's really great. So what do you really want? Do you want to be a medical director? Do you want to do this and this and be a influencer or something? Yeah, right. People don't ask that, and I do not want that. But I would like to have an influence, a positive influence on whoever I'm speaking with. But really, that world's pretty obnoxious. But anyway, but I just say that I'm like, I don't know, but I really don't know the answer to that. But I think that with every gift I've been given and all of the gifts that I've been given as far as learning some of this stuff and hopefully being able to convey it in an interesting, non-boring and educational way, we'll just see what happens. It's been a fun ride so far, and I think I'll keep having fun. And I really don't have an answer for you as far as what that's going to look like, but
no problem.
Next time I come on here, maybe we'll know a little more.
Yeah, well, definitely. So last question, right? And I ask every guest this because I believe it matters. If you could go back and tell your younger version of yourself one thing, right? Not about cholesterol, not about science, but about life, what would it be?
Yeah. So don't get so caught up in the doing that you miss out on the being. Because whatever we're pursuing at the time takes on so much importance. And we're like, oh, life will just be better once I get this degree, or it'll be better when I get this job, and it'll be better when I get this promotion and all this. And ultimately, if the end goal is your entire, if you put that on a pedestal, once you actually achieve that, you'll have about 45 minutes of excitement and jubilation, and then you will come crashing down to earth asking yourself what's next, because it's always what's next. But conversely, if you find joy in the journey and you embrace the process and you realize that, every day is a gift, and whatever you're pursuing, enjoy the process and find the beauty in the journey, man, it's going to be so profoundly, exultantly amazing. And God blesses that more than you could ever imagine. And so, but if the pursuit itself takes on way too much importance, I think you miss out on the beauty of the process. And so that's what I would say, because in certain phases of my life, I did get too caught up in the doing and missed out on the being. I don't regret any of the things that have happened, because even the things that were really, really tough help shape you into the person that you're going to be. But I do think that most of the time our perspective in the situation dictates whether or not we look back on that fondly, or we look back on that thinking, I should have relished that time a little bit more.
Yeah. No one on that, everyone on that deathbed says, I wish I had some more time. I wish I had some more time. So we have time. You have the time. It's in front of you. So Josh, I mean this when I say it, right? This is exactly why I do this show, because we just had a conversation that could literally add years to someone's life, not metaphorically, literally. And I don't take that lightly, not for a single second. I started Uncle Jimmy's podcast because I know that information changes lives. That when someone finally hears the right thing at the right time, something shifts, something opens, and they go home and they make a different choice. They ask a different question. They show up differently for themselves and their family. And today, because of Josh, somebody listening to this is going to call their doctor and ask about ApoB, right? Somebody is going to finally get that LPA test that they've been putting off. Somebody is going to look at their parents' health history with new eyes and decide that their story doesn't have to end the same way. You cannot pour from an empty vessel. Your health is the foundation of every single thing you want to build in this life. Josh, you are doing God's work, and I mean that in every sense of that phrase. You are using your gifts, your education, your platform, your faith, your relentless commitment to accessibility to fight for people who don't even know they need fighting for yet. That is rare. That is special. And this world is better because you showed up, my friend. Thank you for being on Uncle Jimmy's podcast. God bless you, brother. And I appreciate you for coming on.
Thank you so much. Right back at you, my friend.
So before we go, right, I want to give a call to action to my listeners. This one's for you, family. Here's your homework. And yes, I'm calling it homework because I care about you too much to let this just be a listen. Go get Josh's book right now, not later, right now. The Home Security System in the Lipid Neighborhood. It's on Amazon. It is available wherever books are sold, and it might be the most important purchase you make this year. Get one for yourself. Get one for your parents. Get one for that friend who keeps saying they're fine without ever going to the doctor because they're not fine and they need this. 2, make an appointment this week. Call your doctor, schedule a physical, and when you get there, ask for the full lipid panel. Ask about ApoB. Ask about LPA. Use the words you heard today. You are your own best advocate, and now you are armed. And 3, share this episode. Forward it to 3 people who love someone with heart disease. Post it. Text it, because the gift of this conversation doesn't belong just to you. It belongs to everyone you're willing to pass it on to. And if you haven't yet, subscribe to Uncle Jimmy's podcast wherever you listen. Leave us a review and come find us and go all in. We are building something here, something real, something that is about taking your one life and going all in on it. Because you only get one body, one heart, one shot at this. Don't waste it. I'm Jimmy. Go all in, and we'll see you next time. God bless.